Okay, good evening, everybody. Welcome back. We've had a bit of a break, I guess, in our webinar series. It hasn't sort of flowed as much as we'd like it to. But today we are getting back on track and with a big topic, and we're going to break this up into bite-sized pieces as well. We realise there's a lot of demand out there for something about dental radiology. Even we need some tips on dental radiology, and I'll grab them whenever I can. Tonight, we're really just going to focus on the initial bit of dental radiology and obtaining good radiographs. And with good radiographs, we can then get into interpretation at a later date. So tonight, yeah, all about positioning. For those of you that are joining us for the first time, welcome. And for those of you that are coming back who have suckers for punishment, welcome back, guys. I'm Dr. Aaron Forsyth, and with me tonight is Dr. Beck Tucker, and we are the owners of Advanced Animal Dentistry, a veterinary dental referral company based in Brisbane. And we are full-time dental referists. I like to suggest that I'm an enthusiastic amateur, and Beck is certainly like a teeny bit off being a specialist. Okay, so let's get started. Veterinary dental radiology. So you'll have to do. I'll have to do the little ding for you, Beck. Yeah. Okay. We went through this PowerPoint today, and we thought, we scrapped a lot of slides. We're just going to really cut it down to what we think we need. Traditionally, with radiology, radiology, of course, is obtaining X-ray radiographs. And anyone who's an enthusiast, excuse me, because all through the night, I'm just going to call them X-rays. I know we should call them radiographs, but I'm just going to call them X-rays, and I'll probably flip around a bit as well. But with traditional radiology that we use pretty much every day in practice, frequently we use the parallel technique. We are using it. We might not know it actually is called that, but that is the technique that we're using. We do use it in veterinary dentistry, but it is pretty limited in where we can use it. The shape of, I guess, the mouth that we're working in doesn't really allow its use in all around the mouth. So it's only really in the mandibular area, the premolars and molars. So if we look at the next slide, this is just what we do every day. We have an image coming up of a dog having its stifle radiographed. And
ding, sorry, I was just looking through.
Yeah, you're right. Yeah, and so we have the object that's being radiographed is laying on the table, that table is parallel with the DR plate underneath, and the humerus and the tibia and fibula are parallel to all of that. So this stifle is having a radiograph. It's being done with a parallel technique. Now in the mouth, as I said, there's only a small area we can do it in, and as the diagram indicates here, it's really down in that mandible near the molar, molar 1 and the premolars 3, 4. That's the main area we do this. And what we can do is we can place the film in a position where it's parallel with the longitudinal axis of the tooth. So when we do this and we're able to perform a parallel shot, the image that's produced should be dimensionally correct. And I guess that's what we want from our images. We want them to really represent as true as possible the objects that we're radiographing. So this is, as I said, this is an easy one. Well, the next slide coming up, we took some shots last week. I was going to say we took them live. Well, we took them live. Unfortunately, our patient was not alive. He needs a name to skull. But we took images. So the images that you see, we took the two images of the setup, and this is the resulting radiograph that was produced. So here, all we need to know when we're setting up the parallel technique is that the plate itself is at a certain plane. I guess you click on that one back. Yep. So there's the plane of the plate, and the next plane. Oh, actually, we can't see. Yeah, we just shoot it perpendicular to that plate. What we should pick up, I hope we can pick up, is that the longitudinal axis of the molar one is parallel to the plate. Karen's got a question here about 311, and 411. I was really like 311. They can be hard to get in there, and I find them difficult to get as well. Even if I'm using a size 2 plate, I think, oh, this is easy. It should be right there. I find mine dives ventral a lot of the time. How about you?
I tend to pack swabs sort of in the front of the mouth to help keep it from popping forward, and that helps a lot. And the other thing I'll often do instead of going perfectly parallel is to actually come in a little from behind, so angle back towards the tooth, and that will often get it in. Obviously, it distorts the other images, but it tells you if it's there, which a lot of the time you just want to know if, you know, if you're missing one, are you truly missing it? And it will give you enough information about sort of bone loss and the likes of that around it too.
The other thing, as well as packing, pull the tongue forward when you place it in. So then, because the tongue will then just sit back a bit and it'll drag that plate back a bit for you. Yeah, but no, I agree. It can be a tight little spot to get into.
Definitely.
So that's the parallel technique. It's nice. You get really representative images if you can manage it. But the fact of anatomy that we're dealing with is you're limited in scope as to where you can use that.
Yeah. Often cats won't. You'll sometimes get the third premolar in cats, sometimes not, depending how tight they are. And again, like first, second premolar in a dog is variable in terms of whether or not you'll catch it with that technique.
Absolutely. The plate starts to get pushed up and deviated by the symphysis. On that image that we can see, just near your mouth there, Beck, you've got a big black spot. That doesn't look good. Well, what could it be? Still mental foramen. Pretty big. Yeah, you're getting all the points tonight, Karen. Well done. Yeah, so that can be a trick for young players. If you have an angle where a foramen is overlying a root tip, it can be quite distracting and actually can sometimes look like you have periapical disease. Anyway, that's for another time. We're not going to actually talk about that tonight. That's parallel technique. You need to know it and you will use it. But what's the most important really is understanding bisecting angle technique. Bisecting angle technique. It's tricky. So I think first concept to understand, and I'm sure most of you do, again, we all use radiology in some form in practice pretty much every day. But basically, radiographic images are just they're shadows cast by an object when an X-ray radiation passes through them or tries to pass through them. They create these shadows. So I guess it's hard because we take these X-rays with these invisible X-ray radiation, but every day these shadows created by sunlight, and it's pretty much the same thing. So on this slide, this is just a general idea. This is not how we take bisecting angle shots, but if it's a nice sunny day, you walk outside, we've got a palm tree sitting there, and if we have a look at the sun, it's 12:30 in the afternoon, and what do we see? We see a very short shadow because the sun is right above everything, so a small shadow. As the afternoon passes on, the sun drops down lower in the sky, the shadow starts to extend, and this has all got to do with the approach and the angle of approach of the light from the sun. And then later in the day, when the sun's quite low in the sky, we get very extended shadows. This is an analogy of what's going to happen with our our primary X-ray beam as we move it around.
Yeah, so I guess this is basically the tooth, and then the shadow we're casting is what the image is that we're projecting onto the X-ray plate.
Yeah, the ground is our plate, I suppose, in this analogy. Yep. Okay, so into bisecting angles. So parallel technique that we mentioned is really nice. It's a straightforward technique to use, but because of the anatomy of the areas that we're working with, we don't get to use it all the time. It is used, parallel techniques more used in human mouths because we have quite a high vaulted palate, and you can actually get parallel technique of the roots of your maxillary teeth, but not the case with dogs and cats. The palate all of a sudden is right there as soon as we get to the cemento-enamel junction of the crown, where the crown meets the roots in our teeth. So we can't slip the plates up inside the area. So we have to work with geometry, and we have to use the bisecting angle technique. So
Lots of words.
Yeah, we discussed having this slide in here. I thought, look, we have to sort of say it, we have to read it, but we are going to come up with some diagrams and talk about multiple ways to think of this to try and get it to work. I think it can take a while to click for people. It's frustrating, actually, because I think it's a visualization thing more than anything. Anyway, we place our film in the mouth, close to the object that we're trying to take a radiograph of. We try and place it in some kind of parallel situation, but we don't have to be desperate to do that. But what we have to note, and I guess the film part of things is easy. We know that the plane or the line that the plate is sitting in. And then we also have to be able to visualize the longitudinal axis of the tooth or the primary tooth that we're looking at. So each of those lines that are, I guess, associated with those things, the film and the longitudinal axis of the tooth, they form an angle, and we can call that angle AB. With that angle, we should be able to judge that, and sometimes you might see us when we're taking x-rays, we might be sitting there doing a little bit of this action. This is the plate, and this is the tooth. How's it all work out? We're trying to sort of see where things are, and then what we do is we bisect the angle. So we draw a line that splits that angle into two equal halves, and that's line C. Once we can approximate that and visualize where that line C is, we shoot the primary beam of the X-ray perpendicular to that. And that's what it is.
Simple as that.
So let's have a look at some diagrams that hopefully illustrate that as well. So this is the basic geometry of it. Again, we have the tooth and we have the plate, and they form this angle together. Okay. We have that, and once that angle, we can see those two things. Oh, I'm doing a bad image. Once we've got that, then we draw a line halfway through it, which will be a click.
It's coming. There we go.
Oh, sorry, it's formed this angle. Then we click again, and then, yeah, there we go. So we bisect the angle here. Okay, so you have to visualize that. Now, sometimes you can see that quite plainly, maybe with a big tooth like a canine, or maybe even a premolar 4. They're pretty large, and you get a pretty good idea where it is.
Yep.
There are aids to use. Some people use rulers, I know that. Some people use little protractor things.
I'm3 have the little device that's designed to demonstrate it as well. Yeah. I find it's probably a little bit bulky to actually put it in the mouth to use, but if you need like a visual aid to help you get the hang of it, it works quite well.
But you can use it outside the mouth, sort of like looking, have the dog in the distance, and you'd be looking through the angly thing at it to try and work it out.
Yeah.
But you just have to be able to visualize this bisecting angle, this line that halves that angle.
Yeah.
Once we know that, boom, we shoot primary beam with X-ray through that. So it's perpendicular to that. Sounds simple.
Sounds simple, doesn't it?
Simple. Another way to visualize it, I was doing a workshop a few years ago, quite a few years ago now, and one of the participants, they had grasped the idea of bisecting angle, and they said, oh, it's just like this as well. So another way to visualize it, and we realized it looks a bit weird when we do this, but the tooth and the X-ray plate form the two equal sides of an isosceles triangle.
Even though it doesn't look like an isosceles triangle at the moment.
And we realize that is because the white line is shorter than the black line. But believe me, that is an isosceles triangle. So if you can picture them as the two equal sides of an isosceles triangle, your primary beam is going to run parallel to the base of that triangle. Okay, and so when that beam shoots through there, the shadow it casts on the plate will be dimensionally accurate. Okay, and if we click that, we can see that they're passing over the tooth, and on the other side on the plate, the image that will be created will be dimensionally correct.
That technique makes no sense in my head. I like bisecting angle, but I think this makes more sense in Aaron's head. So I think that's what we've found over the time, is that what makes sense for one person doesn't make sense for the next. So trying to look at different ways to actually understand it. You might find one that clicks with you, but it doesn't click with a colleague or what have you. So, yeah.
And I guess we would like people to really pursue truly understanding what's going on. I'm not sure if I kept that slide in, but, and I'm preempting it if we did. I know there are charts out there talking about, well, this is how you set it all up. And that's fine for the dog that was in those images taken, it worked fine. But the way that it was worked out in the first place is by using this theory. Okay?
And it works in the perfect sort of dog, like you've got a Labrador head or even a Greyhound head or something like that. It's great. If you've got a Brachy or something that has slightly different anatomy, then it doesn't work. And understanding, I guess, the underlying fundamentals of it just allows you to adapt. Like, to be honest, like we basically use fairly set angles in terms of, I know for most patients it's going to be about this angle, and that's where I'm used to holding my x-ray generator, but we also can adapt it really quickly for the individual because we have that understanding. So I guess if you do that, you'll probably find that you get a big improvement in just the quality of the images that you get and the ease of interpretation.
Yeah, that's right, Karen. There's no standard way. All you want is you want to produce an image that is dimensionally correct and best represents the object that you're radiographing. Yeah. And yeah, sometimes I find that too. Radiographs are a little bit like ultrasound for me. Ultrasound I can't watch being done. I don't understand it. But if I do it, well, I still don't know what I'm doing, but I sort of have an idea.
It's always more, I find if I've taken the image, it makes perfect sense in my head. If someone else has it, takes me sometimes a minute to go, where are we? Or if it's not exactly the angle I'm used to seeing, it can make it harder to interpret.
Because we were there when it was taken, so we have the other information that's involved with this. We should have probably said at the top that we love radiology. I've been dragged kicking and screaming into doing more. But I certainly do a lot more than I ever used to. And it's a wonderful diagnostic aid, but it's a diagnostic aid. It's not the be all end all. It's not the only thing we should be looking at. It's just one of many bits of data that we use to make decisions. Let's repeat this all again, this time with slightly different colored images. This one here, so here's a tooth. Looks like it needs a bit of a clean, it's a bit yellow, a bit gross. See here, and our plate goes in there. So again, we need to understand two lines that form the big angle. So line A, not sure which one it's going to be. I can't remember whether it's the tooth or the plate. Oh, it was the plate. So the plate is line A, and the longitudinal axis of the tooth is line B. Now, clearly, the teeth that we deal with aren't always straight as well. So you need to take an average of the longitudinal axis.
And you also want to look at the root structure. That's the other thing. When you're working out the angle of the tooth, it's not always the way the crown's positioned. So on a canine where you've got a curvature, I look more at the root angle because that's, I guess, what we can't see with our eyes. We're relying on the radiographs to take images of what's under the surface. So we want the root to be the thing that we're projecting, or the image we're projecting, in a non-distorted way.
Yeah, exactly. Yeah, that's right. The object, you need to know its angle, I suppose, might be the best way to say that object of your radiograph. So we've got A and B, and they form this angle, AB. And we'll bisect that, C, and we'll shoot it with a line perpendicular to that. Brachycephalics are just another lecture.
We will when we're talking about.
Yeah.
We've got some images coming up.
There's a thing coming up we'll talk
Yeah,
about.
Karen just asked if we could talk about brachyes specifically and positioning techniques for them. So when we talk about some x-rays that we've got coming up, we'll talk about brachyes in combination.
Best way to look at, if they're overlapping, Karen, just take a couple out and then you'll be able to see the one you want. And so we've got this, and we're going to shoot this image, and a beam comes through, and the shadow that tooth is going to cast on the plate when we do that is going to be dimensionally correct. Click through on that one.
Oh, hold on, because I've been out, it doesn't click straight away.
Yeah, so if we follow it through, we'll click it again. Yes, it's been photoshopped to be created, but the image, it is true. That's the way the geometry works. You can't argue with maths. That's just the way it is. So that's when it's right. So what can go wrong? So in the next slide, if we look at this, if we're we're shooting really at the tooth, we're getting really perpendicular to the tooth. What we're going to do is we're going to get elongation of the object.
So think of that as the sun being late in the afternoon. So the shadow that we're casting, you get long shadows in the evening or the afternoon when the sun's low. And that means that your X-ray generator or the beam that you're creating with your machine is going to create a long shadow of that tooth on your plate.
Versus when it's high noon and the beam's far too high and aimed nearly straight at the X-ray plate itself, we'll get a foreshortened image. Now, keep in mind, this has all got to do with whatever angle has been produced between A and B. And if we have A and B as a very, very acute angle, so sub 20 degrees really, the bisecting angle is only 10 degrees, you're nearly at a parallel technique. So the image is going to be pretty right. Okay, so I think that's it for diagrams. Yeah, so let's look at some shots.
So these ones specifically, I guess one of the things we wanted to talk about is the way we take x-rays. It's possibly a little bit different from what I think a lot of vets have been shown when we have people come into practice or we talk to people and even talk to a lot of the vet students coming through that have been out in practice and have seen other people taking x-rays. I think a lot of us follow that chart that was produced, and it basically has the patient in either ventral or dorsal recumbency. We don't tend to, I guess, roll our patient to allow us to take the x-rays. We'll take the x-ray in the position that the patient's already in. So we perform our dentals in lateral recumbency. I know there are people that do it in dorsal. So for us, we don't roll the patient. If we've got them in left lateral recumbency, we'll take all of the images basically of the right-hand side without rolling them. We will sort of move and manipulate their head around to facilitate sort of getting the actual generator into the right position. But we find that by doing that, one, you're not irritating your nurses by rolling them too many times and getting all the leads caught under them and twisted. It's also possibly a bit safer for the patient. If you're rolling them less, we've got less risk of things like regurgitation and the likes of that. And it's really helpful for workflow. We can get them basically anesthetized in their, whatever side we want to start on, and we can have that side radiographed in a matter of 4 or 5 minutes. And we're not sort of, rolling and having to manipulate the patient to get that series of x-rays. So I guess we want to talk about how we do that a little bit today. So hopefully that's something that might be beneficial and it might help with workflow as well.
I guess just on that note, Beck, I appreciate the way some people do it as well. The other way to do it, I know that there are practices out there that they'll take all the radiographs of the whole mouth first. So then hopefully in conjunction with an examination, that information can be sat down with for a couple of minutes, and examine it as a whole. Yeah, if that's the way you'd like to work, go for it. But I agree.
We'll often do that depending on owner. If we have an owner that's happy for us to do whatever needs to be done and they don't require us to contact them to do that, we'll do one side, complete it in total, and then do the other. If I have an owner or I'm not sure what I'm going to be doing exactly in advance and I need to speak to an owner about something, I'll radiograph one side, roll the patient, radiograph the other side, contact owner, work on that side, and then roll back, and it's still only moving the patient twice.
Yeah, but I agree, and that's, I think, the downside to working like that is you have just a little bit more movement. Not a lot necessarily. One more roll back is usually about all you ever need, but it's more movement, and every movement under an anaesthetic is a little risk. Yeah.
For sure. So this one is our, I guess, maxillary premolar shot. I guess we will often use in a bigger patient a size 4 plate. So if you've got a CR system, you can do that. If you're using the DR, you're probably limited to a size 2 plate, which we did for a number of years. It just means basically taking a few extra images, but the concept's exactly the same. I think the beauty of using these size 4s is as well that you can do a good survey shot if you're not necessarily looking specifically for something, you're just doing these as a survey view. It gives you a good overall impression of what's going on. And if you've got a dog with reasonable anatomy, not a brachy, you'll generally be able to see everything you need to see on potentially that one image as well. So you can see if we click through, we've basically inserted the imaging plate. We do tend to use swabs to help keep it in place so it's not moving around too much in the patient's mouth. Again, I have it so it's sort of slid in under the tooth and the side of the film's resting against the palate. And with that, generally speaking, as a bit of a I guess cheats way, if you want just a basic angle to start with, I'll generally, it's somewhere between sort of 45-50 degrees to the table for most patients when they're on their side. But if we follow the bisecting angle technique, essentially you can see that we've got the angle of our plate, we've got the angle of our tooth, we bisect that, so cut that in half, and our beam comes in basically perpendicular to that. And the image on the right is what we're then projecting. So we've got, I guess, a nice projection of that anatomy. We don't have elongation of the roots or foreshortening going on, and we can sort of get a really good idea of what's going on there.
But importantly, when going back to what you mentioned about these larger size 4 plates and using them for surveys, teeth at either end of this plate, they are not necessarily fitting in a bisecting angle. And so that's why they may be distorted. So we're not necessarily going to get those guys dimensionally accurate.
Yeah. So for those ones, again, if we've got a brachy, I'll often drop down to a size 2 plate for those ones so I can hone in a little bit more on the anatomy. Or if I'm looking specifically at a premolar 4 with a fracture and I just want to sort of focus down a little bit on that, I'll flip to a size 2. Whilst the, I guess, what's the word I'm looking for, Aaron? The quality of the image is the same. There's not as much going on in terms of your eyes not drawn to so many other things. So I find looking at specific teeth on a smaller plate is really useful for me rather than using, so if I pick something up on the size 4, I'll often grab a size 2 and hone in on that so I can focus down a little bit more.
On that point too, Beck, I think this is actually taking a couple of steps back and talking overall about radiology and nearly specifically about digital radiology. We've gotten potentially, and this is my point of view, I think we've gotten a little lazy with digital radiology because with our software, we can manipulate these things. It is actually still really important that the exposures that you take are good exposures. Don't just crank it out and just blast away. you should be adjusting exposure lengths for tissue thicknesses. You don't have to actually change them a lot. The patients and the tissues that we image don't vary a great deal, but you really do need to make sure that your exposures are good, because if you're having to manipulate, as much as it's relatively easy to do, if you have to digitally manipulate the images, you need to look at what you're doing in regards to the power.
And specifically on the IM3 software, so if you're using a CR7, which I think is the most common, I guess, software or processing stuff that people are using. If you look at the side of the image, when it comes up, you'll have a bar on the side of that. It'll be red for underexposed. I think they're yellow for suboptimal, or is it red for over? Can't remember, but green is what you want. So green will sort of sit in that, I guess, region that the image quality is good and the software isn't doing a lot to manipulate it for you. So
you're getting a nice range of contrast.
Yeah, for sure. I guess it also depends on even just giving our sort of blank sort of, we use this sort of 0.35 seconds or something. That is great. But if your collimator is a different length, or you have a really short sort of, collimator or what have you, or if you're pulling back from the patient further, so you can expose a large area, that's also going to impact sort of the exposure that you need and use. So you've just got to adjust a little bit based on that.
Yep, distance squared, got to remember that. It really amplifies the change in distance. Your plate and your machine are different to the next door's. You have to work with yours. You can't just, everyone else's numbers are a good starting point for sure.
And you don't have to manipulate them much. That's the thing. It's nothing like the rest of the body. But yeah, I mean, when I'm doing them, I'll go anywhere from 0.2, 0.25 for a cat up to 0.5 and sometimes 0.6 for a staffy mandible, because they're so thick and dense to get through.
But for me, my mobile machine, I don't have the long collimator on mine. So I'm up a lot closer. And so I'm using a lot lower levels. I'm seeing around 0.1 to 0.2. But we get similar image quality.
Yeah. So it does just depend on that. So remembering again, like you said, your distance squared is important. I guess to also sort of, bring in some of what Karen asked with the brachycephalics, I guess when we talk about the SLOB rule, if that's something people are familiar with, and or just rotating, not just in the vertical plane, rotating around your patient's head as well. So if I've got a brachycephalic and I've got some teeth that are rotated, if I want to focus specifically on that tooth, I'll use again the smaller plate, but I will keep my vertical angle the same, but I'll rotate around in a horizontal plane. So I'm sort of got my generator coming face on to that tooth, and that will often sort of reveal the anatomy of that particular tooth quite nicely, but you'll probably get distortion of the teeth around. So in brachy's, we're often just taking more images almost of individual teeth rather than trying to do a survey shot to get a lot in one image.
So we'll see the SLOB rule come up in a few slides time.
Yeah.
So same teeth, but this time it's noon. So we've come up really steep on this, and we can see here when we shoot this, like we're going to form our angle here. So what's the longitudinal axis of the tooth? We click that. There it is. Let's bisect that. What we haven't done, we haven't shot perpendicular to it. We're actually shooting pretty perpendicular to the plate. And the resultant image has foreshortened everything.
Yeah. So I guess essentially the X-ray beam is, creating quite a short shadow.
Yep. But later in the afternoon, we get a little lazy and we can't push our machine out. And so the next image shows what happens if we're shooting too much of the tooth. And we just get these really distorted, elongated images. Actually, honestly, for me, these tend to be the most common problems that I cause when I'm not concentrating and not getting my angles right. I tend to get quite long, distorted images when I'm not doing my job right. Yeah, so again, on this one, we're going to make a bisecting angle, been the same as the last 3 shots, but this time we're going to throw it all to the wind, and we're not going to bother looking at the bisecting angle. We're going to shoot wherever we want, pretty close to on top of the tooth. Sorry, perpendicular to the tooth. And yeah, that's the image that we get.
Yeah, and you can see the angle basically between our plate and our beam is too acute.
Yeah. Yep. So a big, long, stretchy shadow in the afternoon.
Yeah.
I didn't do what Beck asked me to do this afternoon. We're going to rotate this image. So forgive me. We don't normally, we're going to talk about this too tonight. We don't normally, this image on the right, we don't normally orient that image like that. That should not be really displayed like that. This is an incisor shot. So maxillary incisor shot. We're going to look at the sort of, I guess, the top image on the left, and we can look at the plate. We can see the plate angle when we click on that, and that will show us the plate angle. And then the longitudinal axis, we're looking at incisors here, not really canine.
This is also where I said we don't want to look at the angle of the crown because that's straight up and down. We want to look at the angle of the root, which is basically traveling in this direction.
Yeah, and you have to take the average of it, because all those roots curve, and all 6 roots there, and then none of them are in this. Well, sorry, each pair is probably in the same plane, but they're not all equal. So let's take an average of them, and this is the image that we can observe. Nice image of the incisors, but what we can see here, if we don't really use this shot for canine teeth, because we've got a lot of overlapping in this dog with the premolar 1 and premolar 2 there. So yeah, we can see a little bit of canine, but a lot of it's overlapped.
It's not a diagnostic shot for a canine, that's for sure.
No, we'd like to avoid that shot. We're not going to use that shot. So how do we do a canine? Well, this is what canines is where it starts to get a bit tricky and actually a bit cooler. So if you thought you knew bisecting angle, you got to do it twice in this shot. So to really get the best images of maxillary canines, we do have to bisect at 2 different angles here. Now, as we click through, we can see where the film is. And again, films are always obvious where they are. But in the top image, when we click through again, we're going to do a look at the longitudinal axis of the tooth from the side.
So again, it's not the crown angle that we're going from. It's basically more the root angle, and the root's traveling sort of up here.
And then in the bottom image, we're looking horizontally. We're going to look at the axis of the tooth there.
So we're sort of rotating around the head a little bit. So instead of coming straight on, I'll have my X-ray beam off to the side about 20 degrees or so.
Yep. And both of them, when we click through, we can see a bisecting angle, and we line up our X-ray generator to try and hit both of those bisecting angles perpendicularly. And it can be done, of course. We can do anything. And when you do, that's the resultant image. And that's a great image. I think that's really nice. It helps that dog doesn't have lips in the way.
There's also, there's just another question about, should we do maxillary premolars and maxillary canines in the same image? You'll sometimes be able to without too much distortion of the canine, but it's probably less common that you'll be able to get good shots of the canine and the premolar together. So again, if you like it and you're happy and you think that, you get a diagnostic image, fine, but I will generally specifically try and take a shot of the canine as well.
Again, coming back to this idea between survey and then specific focal shots, you can get a lot of information from, even if you're not exactly focusing on those teeth, as long as they're not too distorted. So yeah, I do, and especially your smaller dogs. I think you can catch enough of a canine that I'm comfortable with it. But again, if there's a question mark here, we'll focus quite specific on the canine.
Absolutely. And again, if you've just not got that perfect anatomy, then you'll probably find that you do need to take another image.
Yeah. So yeah, maxillary canines, you can certainly make them look pretty nice. Now, again, yes, we specifically set out to take all these images last week, and yes, we took a bit longer than normal, but not a lot. Again, we've practiced at it. This is a manual skill as well, so you just have to practice.
I guess going back to that as well, the other thing I guess that I do with my positioning, what I'll try and do with the plate is actually keep it fairly flat along the top of the roof of the mouth. So I'll generally put the plate so it sits with the tips of both maxillary canines against it. So it's not sort of then angled within the mouth itself. It's sort of just coming in absolutely flat, and that takes, I guess, that other little bit of distortion out of it and makes things a little bit easier for you to actually get your angles right.
Yeah.
In a particular shot.
I agree, Beck. I've started doing that too. I've been doing that for a little while now, and I think it makes it a more standard approach.
Yeah, it gives you a bit more consistency. I'll usually
your film is running parallel to your palate, so you don't even sometimes have to sort of.
And if it wants to sort of rotate on the ET tube, I'll usually just pack some swabs in there. Even if you've then got the patient's mouth propped open a little bit, that's fine. You've got your plate sitting in a consistent way for each patient. So it just helps to standardize it a little bit more.
Yeah. And I do it for the next shot that's going to come up as well. I pull it. Now this guy's tongue fell off, but the tongue, you pull it through and put the tongue through the canines and have it sitting. And our plate does sit on top as well.
Yeah, that again stops it sort of doing that rocking thing and just takes that little bit of difficulty out with that sort of, I guess, the horizontal sort of plane for you.
I've not had the opportunity to use those plastic guards, Karen. I know what you're talking about. I've not, as I said, never even used them.
Yeah, I don't think that, well, we haven't got too much damage to our plates. So this one that we've used back, I think the last one has a little bit of a bit of damage on it. That plate's 2 years old.
Yeah. I can see on this plate that's on the screen, there's some rolling of the film on the left-hand side there, that you can see the white mark up along the left-hand edge. That's because the blue film's coming up a bit.
Yeah, that's processor.
All the damage of the plate itself has not really been from the animals, it's been from us.
And I guess it can, I've used it a couple of times, but I found that the thickness of that sort of guard did make it a little bit harder for me to get the placement of the film. The one thing I really like about the CR films is that they are that little bit flexible and they're very thin, so you can get them into places where I guess previously when we were using DR, we would struggle a little bit more.
Yeah, and Mike's suggested that I imagine it's because of the thickness, and I agree, because this is what we did go through with DR. The parallel technique starts to get difficult too, because it's just so bulky.
Yeah.
So we're going to take a shot now of mandibular canine. Same kind of idea. This is really looking at bisecting angle in a couple of planes. And if you get it right, you should be able to highlight that mandibular canine by itself.
Yeah.
There's a lot going on here at the front of the mandible there. We've got symphysis, so it's quite a tight little area with stuff going on. So it can be hard to get, but if you, again, you just follow these basic rules, get your fingers in the air and draw your lines, draw your angles, find that bisecting angle and hit it perpendicular. Your images are going to come out.
And again, I guess we're not sort of following that crown. We're looking at the root going in sort of this direction more. So you've got to always keep in the back of your mind where the root's sitting. With this particular one as well, or to get the shot of the mandible, that's probably the one I find, or the rostral mandible, the most challenging without moving the patient. So what we'll often do is get a roll of vet wrap or get a bunch of swabs and just roll them up. and put those under sort of the muzzle or the cheek of the patient to lift their head up a little bit. You could also use one of the small sandbags just to get it elevated off the table a little bit, and that will help you sort of get the generator to come in at the right angle. Otherwise, I guess if it's sitting on your actual table, getting the generator low enough to come in at the right angle can be quite difficult.
Yeah, absolutely.
Anything else we need to say about that one?
Not really.
No. So this is the more traditional sort of straight on rostral mandible shot. Again, we'll generally use that for survey views just to see if we've got anything going on. This previous image, when I flick back to that, I do tend to like it, and I'll generally probably take these, but I guess if I've got a young, perfectly healthy patient and I'm not really worried about stuff, I'll settle for just that straight sort of AP type or ventral dorsal view. This one I recommend you use it in cats if you're ever worried about tooth resorption in the mandibular canine tooth. Getting 2 angles of that mandibular canine is essential in determining, 1, if there's tooth resorption present, and 2, how significant it is. We had one today. We're on the standard sort of projection. We were like, oh yeah, it's got resorption, doesn't look that bad. Yeah, we'll probably be able to extract that normally. And then when we did this view and looked at it at a different angle, there was absolutely no way that tooth was coming out, and it became a crown amputation. So it can save you a lot of grief in terms of risking jaw fracture and the likes of that in some of these old cats. But it can also help you detect a lot of more subtle pathology in these teeth as well.
Yeah, which is actually brings in this interesting point that I've always thought about with dental radiology. With all other radiological views we take around the body, we will never settle for one shot, and we shouldn't settle for one shot. With teeth, sometimes we only get one shot, but as Bex indicated, the more shots you actually get of it, the more information you have. So it is valuable where you can. And yes, it takes time, but certainly if there's anything just niggling at you that it's not right, yeah, take a different view.
Yeah.
Absolutely. And this one's a classic one for having to have the head raised. You're not really going to get this if you're lying flat on the table in lateral recumbency, like how we work. Sure, if you're in a dorsal recumbency, that's a no-brainer, that one. That's pretty easy to do. But if you're in lateral, then you will have to prop the head on that.
Yeah.
We don't really show it in the talk tonight, but yeah. Now, of course, that symphysis is not correct because it's a desiccated skull, but symphysis come in there's a lot of variation to symphysis. It's a joint. Always remember that, it's a joint. So you should not see complete fusion. You sometimes see complete fusion, but it's very rare.
Yeah. There's also a question about the distance of the X-ray from the patient's head. Honestly, I go fairly close. If I'm imaging a size onto a size 4 plate, I'll probably be maybe 5, maximum 10 centimeters away from the patient's head. If I'm doing it onto a size or using a size 2 film, I'm like leaning right up against the soft tissue of the patient, because we're not going to get this coning. So you can see that there is a little bit of coning on this image. And that's because I guess we have come down in our distance, but by reducing the distance, we're also reducing our exposure factors and the radiation dose to the patient. So
yeah, which is important to remember, because our dental X-ray machines, they don't actually generate a lot of radiation. So if you're pulling back too far, you're really going to have to compensate by increasing your time, and more time, particularly obviously if it's handheld, you get the shakes and you'll get blurry images as well.
Yep. Yeah.
So you stay right on top of it, basically. I think the guideline generally is just keep the collimator basically on it.
Yeah, yeah. So your collimator, it's a little bit smaller than the size 4, so that's why I pull back that 5 centimeters or so. And that is what you can see on with that patient has produced this image. So we've got the coning on the corners, but it's not cutting off, I guess, anything that's actually relevant to this patient. We've got all the relevant anatomy in, and with a size 2, so you can just be straight basically with the end of your collimator on the patient's soft tissue. So moving on, so we can not keep you all up too late.
So yeah, so Beck mentioned it before, this SLOB rule. To some of you, you may have been exposed to it previously. We actually don't use it a lot in practice, but it's an important technique to know about and understand. And what we use it for is we're using it to work out the relative position between objects on a film. And we do that by changing the shot we take, and the movement of the object on the plate relative will tell us where it sits. So when we are doing it, what we're looking at is we're comparing the object to the direction of movement that we're moving the X-ray head. And SLOB is an acronym, and so that's it on the bottom of the screen there. So S is same, L lingual, O opposite, B buccal. So the positional terms there, the relative terms there, same and opposite, have got to do with, well, what's the object doing? Is the object moving in the same direction on the image as what you've done with the X-ray, or is it moving in the opposite direction of what you've done with your X-ray beam? And the L and the B have got to do, well, that is where it's going to be sitting relative. Is it going to be sitting on a lingual position, which is away from the beam? Is it going to be sitting on a buccal position, which is towards the beam? It can be hard to describe, so let's try and do it with a diagram. What we have here, we have 3 different positions of an X-ray beam. We have our more standard one right in the middle. We're taking a picture here, and this time it's a pretty big X-ray machine. We're taking a picture of a tree, let's say palm tree from before. Now this time there's a little lizard and it's sitting on the back side of that tree. Now when we look at it, if we see what that image looks like when we take it straight through, we won't see our lizard. We'll just see a tree.
You might get a bit of a summation sign or something with that additional density sitting behind it, but you won't be able to make out those 2 objects separately.
Yeah, so where is it? Is the lizard on the front of the tree? Is it on the back of the tree? We don't know. So what we do is we move our image. So we keep our bisecting angle correct, but we rotate ahead of our X-ray machine. And when we do that, and we've got another set of images coming up on the next slide, the object that we're looking at here in this one is the little lizard. So when we move our X-ray machine to the left-hand side, all of a sudden the lizard appears and it's on the left-hand side of the tree. If we move it on the right-hand side, the little lizard moves to the right-hand side. So both times, the lizard has moved the same as the X-ray. So same is lingual. So that means it's a distant to us. Yeah, I do find it tricky. You had a question there? Someone asked a question.
We'll get to it in a sec. It's about imaging 307, even 8 and 9 or 305 with a rigid DR plate.
Okay, yeah, sure. So another way to visualize it is you can do it right now when you're sitting in front of the computer. You can just put your hand up right in front of your face. Just look at your 2 fingers. Now, what you're looking at is your index finger, and your middle finger is occluded by that. Now, we know there's a second finger there. And it's a little bit like these, and this is where we often actually will use this SLOB rule, is when we're looking at the mesial roots of upper premolar 4. When I come around here and look, oh, that middle finger has moved in the same direction as my head. It's come around.
Yeah. So all
So
of
it's
a
moved
sudden
the same. And the opposite is, well, the front finger, so my index finger has moved in the opposite direction. It's moved relatively forward. And that's the SLOB rule. So the next slide is to show that when we're using it on x-rays. And as I mentioned, this is what we will do sometimes if we're quite interested on a specific root and we're actually not sure what root it is, particularly with the upper premolar 4. So this is our standard shot here. Okay? Straight up, bisecting angles all working beautifully. But what we have is we have overlapping roots here. Okay. Well, that's not good. I want to split them up. I want to see a little bit more detail.
It's quite useful if you're looking for things like tooth resorption, or if you are looking at a fractured premolar 4 and you're sort of not quite sure if you're seeing periapical pathology that can indicate, abscess and the likes of that. So we take multiple views again when we're just not sure what's going on with this.
It also comes back to Karen's question before about brachycephalics, when you have overlapping teeth and rotated teeth. Well, if those teeth are rotated, then we're going to rotate, and we can move, and we
it's
can
also quite useful if you've got an object and you're not sure if it's associated with the tooth or not. If you move the x-ray beam and that object stays tightly associated with the tooth root and it moves with it, you know it's associated with it. If it stays or moves far away from it, you know that it's not actual, I guess, dental related pathology.
As we showed in I think one of the first images we had there, when we identified the distal mental foramen. Okay. Oh no, there's an abscess. We just change the angle a little bit, it will move because it's not in the same plane as the root tip. So what we have here, we've moved the x-ray head to the rostral portion of the dog. We've moved it towards the nose. And on the image, what we've seen, there is an object here that has moved in the same way. The object has moved towards the front of the dog. So it's same lingual. Yeah.
So it's like having your hands up and dog's nose is this way. You're moving your head that way.
Yep.
So you're moving the x-ray generated that way. So the palatal root will pop towards the way you move.
So it relatively moves. So we can work out what root that is, and that's the actual palatal root. And I guess the opposite image of that is coming up on the next slide. Shift the tube back the other way. So we're shifting the tube back to the back of the head. The object has moved with it. So the same, that must be it's lingually placed. It's on the other side of everything. So yeah, so we do use it when we have overlapping objects to try and split them up so we can more clearly just identify, not just identify, well, we do identify, but we're just looking at a single object rather than getting all this overlapping material, which makes it hard.
So it does help with 108 and 288 in cats. We haven't specifically gone over it tonight, but we'll probably make a point of it in the next webinar. There are a few different techniques you can use to get better images of cat maxillary premolars. One of the issues that we have is the zygomatic arch will often overlie the roots of the teeth when we use standard bisecting. So there's an extraoral technique that you can use where you have the plate outside of the mouth, and I guess it works a treat, but we didn't want to confuse things too much tonight, so we'll run over that. But yes, it does, you can sort of move in that same plane to separate the roots, but you still won't get an amazing shot unless you're using extraoral in a cat in most cases.
Yeah, what we should do, Beck, we should do just an extra addendum video about that, because that's actually very specifically an interesting and good technique to use.
It is. To answer the other question from before as well, about how to get good images of the rostral premolar teeth, if you've got, sometimes you've got just a really tight symphysis where it's hard to get the plate down, or if you are using the more rigid DR plates, you go back to using the bisecting angle technique. So in that one we showed you of the canine tooth where we were taking that more lateral shot, you'll often also get really good images of the rostral premolars at that point. So essentially you want to put the plate again, sort of, I will sit it on a dog on top of the tongue, so it's not rotating sort of too much in that horizontal plane. And you'll basically come in sort of at an angle like that to the mandible, and that will give you excellent images. I think the best part of changing over to the CR for us was being able to, I guess, image the rostral mandible a little bit more easily with parallel technique. But certainly the bisecting technique can be applied with relative ease to that mandible as well once you get the concept.
It's a nice bisecting angle up there. As Beck said, you put the plate across both arcades, and then those teeth are sitting, honestly, they're sitting at about 90 degrees to that. So what's half of 90 degrees? 45 degrees. So I think it's a good one. It's actually a good demonstrator of bisecting angle technique.
It is. We don't want to hold you up too much longer because we told ourselves we'd try and keep it to an hour tonight. But we did just want to quickly run through, I guess, how to mount and look at dental x-rays, because it's something we find, I guess, it's a funny concept. It's different to how you look at radiographs in the rest of the body. So when we're sent radiographs, we'll often see that people have flipped the images to get them in the standard view you would use if you're imaging a chest or the likes of that. I guess the key thing for dental x-rays is you don't need to flip them. You want to rotate them, but you never need to be flipping or mirroring them.
Unless, and I've never done it, but unless you've taken the image with the plate around the wrong way.
Or you do an extra oral, but you just need to mark that it's extra oral. So essentially when you're, I guess, mounting your dental x-rays, it's called labial mounting. So the maxillary radiographs, so x-rays of your maxillary arcades are placed along the top, mandibular are on the bottom. So there's two actual rows of x-rays. The patient's right-hand side is on your left, and the left-hand side is on your right. So essentially, imagine you've got the dog facing you or the cat. So they're sitting in front of you like you're examining a patient, and that's the way you're viewing those images.
And mandibular teeth are facing up, maxillary teeth are facing down.
Yeah, so we've got little Mapey Moo being perfect little model here. So essentially when we've got those images sort of displayed, we have canines basically to the center. We'll have incisors along here, canines sort of here, and then the premolars along here. And obviously this is going to be the right side, and this is the right side of Maple's face, and this is going to be the left side. Same with sort of looking at this, when you've got your incisors and your canines facing you, this is left side, this is right hand side. So we'll show you them mounted up. Hopefully it makes a bit of sense. So this is just a basic set from a dog. You can see that we did get the canine in this one, and it's not just, it is a bit distorted in this image on the left-hand side of the screen. But essentially we've got, imagine sort of Maple sitting here, her nose is pointing towards the center of the screen. So essentially what we've got is, this is the right maxillary premolars here, canine, and we've got the left maxillary premolars here. With the image in the center here, this is basically our incisor view. So we've got this rotated, so the teeth are, I guess, crowns are facing down. And in the mandible, we
Into the
want the
mouth.
crowns, into the mouth. And we've got the crowns pointing upwards for our mandibular ones. And once again, we've got, this is the basically nose here. Imagine that that's where your nose is sitting. Obviously, this is left side, this is right side. So no need to flip anything. Basically, once you understand this, someone can present you with an X-ray, and as long as they've not manipulated and flipped it, you should be able to tell exactly, one, what arcade it's from, because you'll usually be able to make out details that give it away as the maxilla or the mandible, and you should be able to tell if we're looking at left or right. So we've got a picky of her overlying it. Let me get rid of all my scribble. So that should make it fairly clear. So just imagine you've got that image of a patient in front of you when you're viewing it, toward basically if the rostral teeth are pointing to the left of your screen, you are imaging or looking at the left side. If the nose or the rostral teeth are pointing to the right, you're imaging the right-hand side. And that's just the same thing in a kitty cat, yeah.
Yeah, and I think that's it.
Yeah.
As easy as that.
It is.
It takes an hour to get a good X-ray. So yeah, as that last slide just touched on, it's about understanding the fundamentals, or we believe it's about understanding the fundamentals of how an image is produced. And if you know how it's produced, you can adapt yourself to wherever you are. Here's a show-off moment. If you're X-raying a polar bear that's laying down on the floor and you can't move it, you can get a correct image because you know where your plate is, you know roughly where the axis of the tooth is, and you can work it all out. And once you obtain these good images, then you can go on and interpret them. And again, that's a whole nother lecture.
Which I guess we'll be looking at doing. So if anyone's got any questions, throw them up now. Also, if there's specific things that you want us to discuss, or if you want us to expand on this a little bit more, we're looking at doing, I guess, a whole series on X-rays because it is a pretty complex and big topic. So we can cover things, or if it didn't make sense, we can try and find another way to explain it. And definitely we'll look at sort of going through that extra oral technique for the cat maxillary premolars as well, because that's really useful, and that works nicely for the DR and the CR plates as well. I really did like it a lot when we had the DR plates, because I found it even harder to get decent images of those teeth back then. So tips for keeping the incisor straight when in lateral recumbency. I use basically the prop to get the head up a little bit off the table. So I will sort of usually tilt the nose up with something, and then I'll sort of squat down and have a look at where the right angle is. I think if you're standing above them when you're trying to, I guess, get the image, you'll often inadvertently rotate up or around that lateral sort of plane around their head. So
I think the key to it, Beck, is getting that plate across and having it touching both canines.
Because you don't have that rotation.
You want the plate there, not here.
Yeah.
You can do it there. It's really awkward. But if you do it there, then you just got an idea of a better idea, I think, of where everything is. Yeah, a lot of squats.
Yeah, you can do star jumps to do that.
Even still, as well, and not everyone's obviously has the ability to quickly change equipment, but it's actually why I really like using a wall-mounted unit. So if anyone is actually still thinking and planning on how to set a system up, if you have the room for it, not that it takes up a lot of room, but it requires installation, I love wall mount units because of that. I
The
don't have to.
benefit of that really is that the only thing that I guess changes, and that's one of the reasons I think I liked DR as well, is that I guess you've then only got one variable to play with in terms of if you get an image and you see foreshortening or elongation, your generator's already in the position that you took the last image. So you know where it was, so you can make that adjustment more readily. Whereas if you've got a handheld, you're setting the whole thing up from scratch again. So you're not just making a fine adjustment on an image that you've already got.
Yeah. You've been trained very well, Karen, so that's good. And Donna's got a question here about perspex protectors. Again, no, we don't use them. I don't see a massive value in them. I will bend a plate from time to time accidentally, and I have marked a couple because I've done it. But yeah,
I think it could definitely be beneficial in getting it to sit in and so not bend or sort of flip around as much when you're trying to get it to sit in that rostral oral cavity between the canine teeth. I think that'd be definite benefit there. But imaging more quarterly, I think the bulk of it then starts to make it more difficult to get the plate far enough back.
I guess it can help you identify your angles, one of your angles, one side of your big angle. Yeah.
Yeah, I guess that is another point that I guess when you've got them and you're moving them into sternal and dorsal, you're going to have potentially more weight coming down on the plate with the patient sort of almost actively closing their mouth a bit more, which is true.
And I think interestingly as well, Beck, in the techniques where they're done in sternal and in dorsal, they really do rely on the plate actually being just across the mouth at all times. Every shot is taken with that.
And you're also going to get, again, one more damage to the plate, but more bending. We actually found that the other day because stupidly, when we started doing these x-rays, because the skull sat better in sternal and in dorsal recumbency. So we started taking them like that and then thought, why are we doing this? Because one of the things we want to talk about is how we actually take x-rays.
So a whole series of images showing how it's done in sternal.
And we did find that the plate wanted to walk around a lot more in the patient's mouth. I guess because it does want to naturally then close more, it doesn't want to stay propped open. So you have that essential that's like a pair of scissors closing over it. So it wants to really flip it around. So I guess the other thing that we find in lateral recumbency is that their mouth will often stay propped open a little bit easier, and you can more specifically get the plate into position and it'll stay there. Do we have downloadable resources? It's something that we want to do. It's just difficult. I think with x-rays, it'll be easier. It's something that we would like to do for extraction techniques and stuff as well, with like downloadable PDFs that have drawings and stuff on it. The difficulty is ethically accessing or cadavers to be able to do that with. So it's a work in progress, but we can definitely look at doing something for, I guess, x-rays for sure.
I don't read, Karen, so I don't know.
Textbook for dental rads. Ooh. I have veterinary what one is it? Can't even remember. I'll post it. It's just a general one. I find it helpful, but nothing came close to just doing it yourself and learning. I don't know if I've got something, or if I wasn't quite sure about the anatomy or a little bit of a superimposed structure, then I would refer to the textbook. But yeah, I don't know. I find them useful, but there's nothing that's the same as just taking x-rays and seeing the same thing over and over and learning on the job almost.
Does DeBowers have a good interpretation section, Mike? It's a bit tough asking when you're not.
Yes, or radiology. Yeah. There's a few. I don't know. Personally, I didn't find them amazing. Is that bad? They weren't practical enough for me, I think. I wanted something that was, you know, a little bit more of maybe case-based as well. I find radiology or dental radiology, the interpretation of it really difficult when you don't have other information to go along with it. I guess our plan is when we do more of these to try and get a whole case together for you, so you can see not only the oral exam findings but the radiographic findings as well, and that will often then cement things and make a lot more sense. Yeah, I'm not writing one, Karen. Oh yeah, there's also, we've been reminded there's a survey at the end, just for some feedback. So if you've got anything you specifically want to cover or something that you want to comment on that we can improve on, definitely let us know and we'll work on that as well.
Very good.
Karen has one more. Do we take the orthogonal view when looking for horizontal bone loss on the side of tooth only? No, I use my perio probe.
Yeah, I think perio bone loss is a good one, where I think that because of people put too much emphasis on X-rays, I think it's a physical.
It will pick up horizontal bone loss. It'll pick up vertical bone loss when it's on the mesial or distal surface. If it's on the buccal, lingual, or palatal surface, you'll often miss it. So we commonly see, I guess, dogs specifically with oronasal fistulas, nasal discharge from a maxillary canine tooth, and you'll take a dental x-ray and it'll look pretty normal in a lot of cases.
Poorly evidenced on
and then you'll use your perio probe and you will basically pop it straight up into the nose. So again, that's partly why we say they're a diagnostic tool or an aid. They're certainly not something that will give you all the information that you need to sort of make a treatment plan for a patient.
But your point's correct. Absolutely, of course, as with all radiographs, and this is why orthogonal views are of such good value, you're looking at two dimensions, and so things obliterate each other and you just can't see things in certain views. So,
and you need a fairly significant amount. I think it's 30% of loss of density or something to even see it, so it needs to be reasonably significant. Cool. Well, maybe watch this space, Karen, because there is a CT that does, what is it, 0.1 millimeter slices that's designed specifically for heads. So one day maybe.
Well, we'll set up a GoFundMe.
Yeah,
and we'll
only 250,000.
Yeah, a little bit expensive, but yeah, absolutely. Cone beam CTs they're the future.
They are.
Absolutely the future. But yeah, they're also our future relationship with a bank.
Cool. If anyone got anything else to add at the end, otherwise we'll let you all go and enjoy the rest of your night.